Hi, good evening everybody. The Indian Orthopedic Association wishes all women and women orthopedic surgeons all over the world a very happy and successful International Women's Day. It is very heartening to note that the WOICE, that is the women's cell of the Indian Orthopedic Association, is holding a live webinar today with three stalwart speakers on trauma, pediatric trauma and trauma. I wish them all success. Wish you all the best. Thank you so much.
Good evening, everyone. I'm Dr. Ruchita Mehta, and I'd like to welcome all of you to this very exclusive webinar, which is being aired on the occasion of Women's Day under the aegis of the WOICE. What is the WOICE? The WOICE is the Women Orthopedic Surgeons of India in the IOA Collective Empowerment. It is a historic move on the part of the IOA to have instituted a women's cell in the IOA itself. And we dedicate this entire presentation and the entire women's cell to late Dr. P.K. Mullah Firoz, who was the Iron Lady to take up orthopedics more than 63 years back. Since then, she has inspired many of us, and a lot of women orthopedic surgeons who exist all over India and even some abroad then came together first in 2005, IOCON in Mumbai at the Golden Jubilee celebrations, and subsequently in 2017, once I was appointed to the chairperson of this WOICE cell, that we started conducting activities, and now this is here to stay. We are proud to be a part of the IOA, and we do not want a separate association, but we certainly want to encourage all women to excel in academics, and hence this webinar. In 2017 and 18, we did a lot of CSR activities and osteoporosis awareness and seminars on behalf of WOICE. And in 2018, there was actually a separate session which was conducted in the IOCON at Coimbatore, where we had fantastic talks by some of the senior and middle-level women orthopedic surgeons from all over India and even from abroad. Today's webinar is going to feature three of these speakers, that is myself, Dr. Joan Arakal, who is now in Australia, and Dr. Ruta Kulkarni, who is in Meerut. All three are well achieved and well established in orthopedics, if I may say so myself, because IOA gave us a good platform to go ahead and excel in all our respective specialities. Although each of us pursues a different specialty, we thought trauma was a common theme, and hence we are all going to talk about something related to trauma. Without much ado, and I promise you there will be more and more such webinars, because there are a lot of young women who are bright and are upcoming in WOICE. Without much ado, I think I will roll on to our topic now. This was some of the attendees of the IOCON and some glimpses to see. What I thought would be more appealing to the larger audience would be something that comes to each and every orthopedic surgeon in their day-to-day practice. I am a pediatric orthopedic surgeon, and hence I think something which plagues the whole country is what should be discussed in detail. So let's go ahead and see what are the principles of acute management of the forearm shaft fractures. We'll try and cover a little bit about green stick. We'll try and cover something about complete fractures and plastic deformation as well. When you talk of pediatric forearm fractures, we essentially know that we are talking of radial and ulnar shafts. Are they really that common? Yes, they form approximately 4% of children's fractures after supracondylar and lateral condyle. And why is it so? Because the middle and the proximal radius are a little more protected by musculature than the distal. And hence, any fall on the outstretched hand tends to immediately affect this region. The ulna itself is a subcutaneous bone and is hence very, very susceptible to trauma when raised for self-protection or again for a fall on the outstretched hand, because the activity of level of children is very high. And naturally, greater the age, greater the tendency for the distal fracture, because it occurs in a transition zone between the vulnerable wider metaphysis and the more narrow and stronger diaphysis. Also, in growing children, there are a lot of epiphyseal injuries which happen in and around the metaphysis and both bone forearm region, but we will not address that in this talk because that requires a separate thinking and management altogether. Causes, as I said, the commonest cause is the fall on the outstretched hand. With the increasing level of sporting activities these days, there usually is a disruption on the convexity side, and hence in green stick fractures or in many incomplete fractures, we see if there is a pronation when the child breaks the fall, you will get a dorsal apex to the fracture configuration. And if there is supination, as in the child falls on his back, you usually get a volar apex to the fracture configuration. Besides this, there are other mechanisms like a direct blow, a lot of mountain biking and skateboarding, even in India this is common, trauma as in road traffic accidents, and child abuse. So the incidence, therefore, peak incidence is almost 80% in children greater than 5 years, and naturally it is related to the velocity of growth. Hence, there is a dissociation between the growth and mineralization, which leads to these bones being increasingly susceptible and easily breaking rather than bending. In younger children, you will see bending rather than breaking. We'll come to that shortly. Sometimes they're associated with a lot of other injuries as well, especially if the fall has been really high or the sporting activity has been associated with a lot of velocity. And you can see the list of associated injuries that I have seen here. I have put down here. Let's talk firstly about the younger children and plastic deformation. Why does this happen only in small children? It happens because the immature bone is weaker in bending and therefore tends to absorb more of the energy before the fracture. And rather than having a complete break there because the periosteum is thicker, it tends to bend and twist. Plastic deformation is a very, very unique feature of the pediatric younger bone because the cortical bone has lower content than an adult bone and hence it absorbs more energy. If the amount of strain that is placed on the 2-year-old child does not surpass a certain limit, then the forearm will certainly bend rather than break. Where is it most common? It's common in the forearm, particularly the ulna. Let's see an example. If you look at the ulna configuration here and compare it in the Montagia, this itself, the loss of the ulna bow itself is a plastic deformation, and which in turn, because the force is so great, causes the radial head to dislocate. Yet another example, a torus fracture of the radius and ulna, again thanks to a fall on the outstretched hand, which causes the metaphysis to buckle as shown here. So very often we tend to miss these fractures and one has to look really hard, and you must have a high degree of suspicion when a child comes to you even after a few days of the fall complaining of persistent pain. Otherwise you will miss these green stick type of fractures. So if you have a true plastic deformation, if the child is less than 4 years of age, most of the time it will remodel provided the angulation or the deformity is less than 20 degrees. All you need to do is give pain relief and allow for healing and give a long arm cast for 4 to 6 weeks until all the symptoms have subsided. But if the age is more than 4 years, or the deformity or the amount of deformation is greater than 20 degrees, then an osteoclase is indicated. It is also indicated if the deformation of one bone prevents the reduction of a concomitant fracture on the other bone. Please remember, the forearm is a connected structure. It is also indicated if it prevents full rotations in a child greater than 4 years, or if it exceeds 20 degrees, like I said earlier. It is better to use GA because almost 20 to 30 kg force is required for giving a good correction, slow and sustained, and this is more of an art rather than breaking it completely. What you have to ensure is that the apex of the bow should be placed over a well-padded wedge, right exactly where you want the forces to be applied equally on both sides, and go on gently giving a constant force for 2 to 3 minutes. Once you confirm that clinically as well as radiologically you have corrected the deformity, at least down to less than 10 degrees or less than 20 degrees of angulation, because some of these injuries tend to come late and it may be easier in figures, but in real life it may not be as easy to secure that. So even if you have to accept angulation, make sure that it is less than 10 to 20 degrees, and then you can go ahead and give a long arm cast. When the force is a little more greater than what happens in a plastic deformation, we tend to get what is known as green stick fractures, which means one side of the cortex fractures. And we all know that this is because there is thicker periosteum than the mature adult bone. It bends in places and breaks a little bit depending on how much force has been applied. The management can be either conservative largely, or you need to do a close reduction under GA. Either you can do it in the emergency room or under GA, depending on the fracture configuration. We spoke about apex volar and apex dorsal a little earlier. We'll talk a little more in detail now. So what's the reduction technique? The first thing to be done is to unlock the impacted fragments on the tension side, initially by exaggerating the deformity, which is largely hyperextension followed by hyperflexion, and then give a cast. Apply traction and a reducing force. If the fracture is stable after reduction, but you think there is a increased likelihood that it may refracture, then immobilize for 6 weeks rather than 4 weeks. While doing the reduction, we must keep in mind the Evans concept of rotation, which was popularized in 1950s. Try to figure out whether your fracture pattern is an apex volar or an apex dorsal by looking clearly at the AP and the lateral views. Also, depending on the apex volar, figure out whether it's a supination injury or a pronation injury. And hence, if it's a supination injury, you're going to need a pronation maneuver when you're doing the reduction. But if it's a pronation injury, you will need to supinate the forearm rather than going by the old concept of proximal third, middle third, and lower third. The more important thing in green stick fractures is a derotation, and that is a must. If not done well, then you will have a loss of pronosupination if the derotation has not been achieved in a reduction. In addition to this, there is a radius crossover sign which you must look at in your radiographs. Analyze the radiographs in two parts that is proximal and distal, and use the distal humerus as a reference line rather than the wrist to see whether the radius is crossing over in pronation from the proximal to the distal end. If not, then you certainly have a rotational deformity. In addition, there are other signs which you can look at in the post-reduction radiograph. We'll show them shortly. This is important to keep all this in mind so that if there is an oblique plane deformity and you miss it, you may again end up with rotational problems post-operative. So now to understand this better, let's look at a clinical example. This is a clear case of an apex volar injury, which means the apex of the fracture pattern is on the volar side, which is essentially a supination injury since the child fell on his back. It's a 7-year-old child, and therefore you need to cast in pronation. As compared to this is an apex dorsal injury, which is largely a pronation injury because of fall on outstretched hand. And this you will have to derotate and cast in supination. Now, this is contrary to what a lot of us have been practicing based on the proximal third, middle third, and distal third rule. But however, this is more scientific and this needs to be remembered in great detail. Let's look at a few case examples now. Also, you also need to remember that after derotating and giving the cast, it's important to maintain a good cast index, which means the AP and the lateral diameters should be 0.7 or less. Otherwise, this can lead to a loss of reduction, especially when your distal fragment does not have too much of a hole in case of metaphysio-diaphyseal fractures. So moving on to the case example, this was a 7-year-old boy who fell off from a swing and fell on his back. This is a apex, volar injury. This was treated with a long arm cast with the elbow in 90 degrees range and flexion, and forearm was kept in neutral rotation. When a check X-ray was taken, this was the look of the reduction. Now this is clearly not acceptable because the forearm has slipped proximally. And as you can see, on the re-reduction, this is what the forearm was looking like. Similarly, an 8-year-old with a forearm fracture, apex dorsal pronation injury, cast given in supination, and see the kind of beautiful reduction that you get, immobilization in supination, good cast index, and perfect realignment of the fracture. The story is quite different when you talk of complete fractures. Now you have, in addition to the rotational element, an instability, and if one of the fragments gets locked, the bone then acts like a strut, preventing the other one from reduction. For example, this was casted in the OPD, and this was accepted as a reduction. And when you see this, he's an older child, this has malunited, and he has a complete deformity right between the forearm to the proximal forearm to the distal forearm in the form of an angulation, because the ulna remained straight and the radius had to bow in return and was malunited in rotation. These kind of cases then require a formal osteotomy and plating, and hence we must make all attempts to prevent these kind of mishaps. So what are the criteria when you talk about accepting reductions in complete fractures? There are 3 elements that you must consider: angulation, rotation, and shortening. Shortening is usually not a problem because in the upper extremity, mild amount of shortening does not pose any functional issue. And however, if the child grows, shortening catches up. But angulation, there are limits to accepting angulation, especially in a younger child less than 9 years of age. You can accept larger amounts of angulation, that's about 15 degrees from proximal to distal. Distal a little less, proximal a little more, because the child has more time to remodel and get over this angulation problem. Similarly with rotation, less than 9 years of age, you can actually accept a few more degrees of malrotation to allow nature to remodel it, but there would always be some range of motion issues, which sometimes parents may not be happy about. So ideally you should try to reduce fully, but above age 9 years, certainly the amount of acceptability is less because the child has less time to remodel. So as a rough rule of the thumb, remember the 15 degrees rotation deformity rule, that try not to accept more than 15 degrees of a rotational malalignment. So let's look at a few case examples. Is this an acceptable reduction? Although at first look, this looks like everything is fine and there is a bayonet apposition and this should go on to unite well. But when you actually study the post-reduction radiographs, you will see that the forearm is in pronation as seen here clinically, and the distal forearm is in, the proximal forearm is in supination and the distal forearm is in pronation. So this is a gross rotational malalignment and this should not be accepted. The same radiograph, if you study a little well, and study the diaphyseal alignment here, you will notice that the bicipital tuberosity and the radial styloid, which are actually supposed to be physiologically in opposing directions, are not so in this radiograph. And they are at a 90-degree rotation. So what should be ideally acceptable? The bicipital tuberosity and the radial styloid should be completely opposing each other as 180 degrees rotation. And that's the only way you have restored the proximal forearm supination and the distal forearm pronation, which you have corrected now to full perfect alignment. And even this look of the X-ray is acceptable, as this is more than a bayonet apposition. Almost more than 50% of the shafts are in contact, and this went on to heal up very well, as you can see out here, and perfect function, full range of motion. With so much talk about close reductions and conservative management, is there a role for fixation? Yes, certainly, in open fractures. When the fractures of the both bones forearm are associated with soft tissue injuries. If you have an inability to maintain a close reduction, especially in some children where there are comorbidities which will not comorbidities which will not allow you to maintain the cast. And in refractures, which is a little bit of a relative indication for fixation, but in ipsilateral fractures also, it's a good idea to go ahead with fixation, because the whole segment then becomes unstable, and hence doing a fixation helps you achieve stability and secure a good reduction for both segmental fractures. The preferred modality is intramedullary fixation because it's low morbidity. In very young children, you can use K-wires. In older children, you will use 6 years and above, you will use tense nailing. You need to use C-arms, of course. The tense nail works as an excellent internal splint for good alignment. It may require external support in the form of a slab for a few days. And this is an ideal modality for unstable and open fractures. How does it work? It basically works like an internal strut, as you can see both the tense nails here, because it restores the tensioning of the interosseous space as seen here. This works like a beautiful hydraulic system and is in line with the 3-point fixation, and perfect spindle is formed like the way you would have done for a femur or a tibia fracture, and hence both the bones tend to go on to unite very well. So as you can see again in this cross section, the interosseous space is the one which actually maintains the distance between both the forearms and prevents all the rotation. So when you have a rotational malalignment, this tends to also give rise to cross unions, but with a tense nailing, when you restore the convexity of both sides, you get an excellent fixation. To show you another case example, an older boy, a 10-year-old child with a very unstable fracture pattern and a complete fracture of both bones forearm, which was done successfully with tense nailing. As you can see over there, good alignment, good maintenance of the interosseous space. And that's his X-ray at 1 month. There is a little bit amount of collapse, but which went on to remodel very well later. These were just the initial X-rays. He went on to do very well and get full range of motion. Are we saying that all of them should be treated with only intramedullary fixation? No, there are specific indications for plating, that is extramedullary fixation, for adolescent fractures, for segmental fractures again, especially if they are highly unstable or high velocity trauma. For fracture patterns itself in the long bones where you have a butterfly or a long spiral where tense is completely unsuitable, where you have a lot of comorbidities, all these situations you can go ahead with plating. I'll show you an example later. You should use C-arm guidance but not on continuous mode, and it helps you mobilize the child faster. Very, very ideal for very rotationally unstable injuries where there is lesser amount of hold. For example, in this child, a 12-year-old child with distal radius ulna diaphyseal fracture pattern. This was treated successfully with plating, and this went on to unite very well. He had refractory epilepsy, and hence we could not afford to put him on a tense nail or on a closed reduction. So to complete it, whenever you're faced with both bones forearm, identify the pattern, look for whether it's an incomplete, complete, or a plastic deformation. Incomplete fractures, look for whether your reduction is stable or unstable. If it is unstable, do not hesitate to go ahead with fixation. Keep in mind the age of the child while you're doing a decision making. Younger the child, you will prefer conservative methods. Older the child, you will resort to internal fixation or external fixation as highlighted earlier. And if there are wounds and abrasions, that would change your management. Either ways, in all of the above situations, even in a simple casting, remember that you must monitor compartment status pre-op and post-op. So to succeed in forearm fractures, I think it's very essential to first think about the fracture pattern, analyze what you're going to need, plan your modality well, do it once. If it doesn't succeed, do it again, and keep on doing till you get a perfect realignment. And always remember to restore length of the forearm, restore the interosseous space, and restore the rotational alignment. And I'm sure all your forearm fractures now in children you should be able to do very well.
Greetings, everybody. In my talk today, I propose a new paradigm for fracture healing, one that is based on gradients. We stumbled on this while doing some research on scaphoid fractures. When we compared the optical densities across fracture lines and scaphoids, we found that those showing a greater difference in optical density, or to use a more technical term, a higher optical density gradient, were more likely to result in non-union. As these gradients are induced by the fractures, we refer to them as fracture-induced gradients or simply as FIGs. To further study the phenomenon of FIGs, systematically we analyzed a series of digital X-rays. On each of them, we measured and normalized the averaged optical density in 7 areas. When we plotted these 7 values, we found some interesting results. First, that from the proximal to the distal end, normal scaphoids show a slight natural gradient of about -10%. Second, that fractures show up on X-rays as acutely formed gradients, and that if we follow the optical densities in fractured scaphoids, over time they fluctuate with gradients that initially rise and later fall to their normal natural gradient. And finally, and possibly most interestingly, we noticed the gradient between the proximal and the distal ends of the scaphoid was very different between fractures headed for union and non-union. And importantly, these differences appeared as early as the first week after the fracture. We soon realized that these observations also had some very powerful clinical applications. I will only discuss 2 of them today. The first one is to predict non-union. So if we use -30% as the cutoff to distinguish between fractures headed for union and non-union, then this test would have a sensitivity of 92% in detecting scaphoid non-union. I will illustrate this technique with a case report. Mr. P was a young man who sustained a wrist injury. 11 days later, he had an X-ray in which the radiologist reported a minimally displaced transverse fracture. 39 days later, his X-ray was reported as indicating union. 53 days after the injury, it showed good healing. And 88 days later, all appeared well to the radiologist. However, because of ongoing pain, a CT scan done on day 88 showed non-union, which was confirmed again a month later with another CT scan. He went on to have surgery 2 weeks later, that is a full 19 weeks after the initial injury. But if we look at the FIGs between the proximal and distal end, they're quite high from the outset, around 30% or higher. It is possible that using the FIGs technique, we could have diagnosed a high probability of non-union from the very first X-ray and surgically intervene much earlier, saving the patient a great deal of inconvenience. Let me now describe a second tool. Consider how we immobilize fractures, irrespective of whether it is my 78-year-old mother, myself, or my 26-year-old daughter. If any of us broke a forearm bone, we would all have it in a cast for 6 weeks. Why 6 weeks? It's quite unlikely that my daughter should need nearly as long as me to heal a fracture, or that I should need as long as my mother. Yet we choose 6 weeks because it functions as the safest common denominator. If we had a biomarker which could tell us when fractures have healed, we could individualize the period of immobilization. The transient gradients we discovered provide such a biomarker. I'd like to state that measuring fracture-induced gradients has the potential to transform clinical orthopedics. So far, I have discussed the clinical application of FIGs, but it is the scientific import of this idea that is probably even more exciting. Devoid of the blood and drama, a fracture is simply a bony gradient, and fracture healing is simply the resolution of that gradient. but there are some key differences. The gradient that results from a fracture is one that is acutely created, and being in a bone, it is a fixed gradient. By contrast, the resolution of this gradient resulting in fracture healing is a gradual process, one that is facilitated by the chemotactic migration of osteoblasts and other cells. A bit of copy editing will then yield a definition that fracture healing is the gradual chemotactic resolution of an acutely created fixed bony gradient. Is this a significant definition, or is it simply stating the obvious? Besides the clinical tools I described and potentially billions of dollars in economic value, positing fractures as gradients provides a whole new way to think about fractures. It moves us from structure to function, from anatomy to physiology, from the static to the dynamic. In that sense, one may go so far as to say, this is not simply a new definition for fracture healing, but one that changes the scientific paradigm within which we have operated for the last few centuries. To me, this has been the most exciting part of the work. Let me now change gears slightly. While I'm very pleased to be presenting this on the International Women's Day, I'm also acutely aware of why such a day is necessary. Though globally we are seeing women tending to parity with men in graduating from medical schools, by the time orthopedic training is completed, more than 96% are men. Numerically, women have been and remain marginal in orthopedics. It has long been asserted by the male practitioners of orthopedics that this is not a specialty suited to the fairest sex because of the need for brute force. Picture this: a few men holding down a screaming victim of a saber-toothed tiger's attack, having bottles of benumbing hemlock poured down his throat while having his leg amputated with a large saw. In such a situation, I would gladly defer to a male surgeon. Yet this image belongs on the walls of old royal colleges. Times have changed, societal values have changed, and importantly, technology has changed. Developments in anesthetics, muscle relaxants, and power instruments have leveled the playing field with respect to the need for strength. The focus today is on good technique, and brute strength may even be a disadvantage. However, the attitude to women in orthopedics has not changed apace. This has seriously affected the scientific development of orthopedics. Fracture treatment as we practice it today grew out of the bone setter's trade. In principle, what we do is really no different from what our medieval counterparts did. We immobilize fractures and wait for nature to provide healing. Though the results we produce today are better, this is mainly because of developments in areas outside orthopedics, areas like anesthesia, antisepsis, and material sciences. However, from within, orthopedics has produced very little scientifically. Our approaches have largely remained ossified within the mindset of medieval bone setters. Various academic disciplines globally have shown us that their own paths to greater scientific development have been paved through the modernization of their workforce by the inclusion of women. Orthopedics has spectacularly failed in this regard, and we need to learn from them, not because women need orthopedics, but because orthopedics needs women for its own scientific advancement. When I see what Indian lady orthopedic surgeons are achieving, and with good leadership, it provides reason for optimism that the future of orthopedics will be much brighter than its past. It's not surprising that this is happening in the country which has twice as many women pilots as the global average. I would like to congratulate you all for your stewardship and leadership in modernizing orthopedics. Thank you.
Good evening, everyone. It gives me great happiness to talk before you on this occasion of Women's Day. I wish all of you a very happy Women's Day. At the outset, I must thank Dr. Rujita Mehta for giving me this opportunity to participate in this webinar. And I must thank Indian Orthopedic Association for starting Women Orthopedic wing, that is WOICE. I come from an institute where currently 6 women orthopedic surgeons are working, and I really feel proud about it. Today, I'm going to talk about post-traumatic deformities and non-unions, and I'm going to highlight role of ring fixator in these. As we all know, incidence of high velocity trauma is increasing day by day, and complex and compound trauma can cause severe complications. The main causes of post-traumatic deformities are bone loss, soft tissue loss, malunion, non-union, growth arrest in children, and last but not the least, infection. Ring fixator is a very useful tool to treat some complex fractures, non-unions, and deformities. Elizarov is indicated in open fractures with bone loss, soft tissue loss. Then even in fractures with diaphyseal comminution, and in tibial plateau and plafond fractures as well. So this is one of such fractures. It's an open fracture with bone loss. You can see there is significant soft tissue damage. So Elizarov fixator was applied. All the loose bony pieces were removed. The devitalized bone ends were resected. And then the fracture site was compressed gradually, and corticotomy was performed proximally to gain length. So he went on to unite very nicely with only minimum plastic surgery procedures needed. One more such case. This is a 14-year-old boy. He came 2 months after the trauma with this fixator on. He had bone loss and bad infection at the fracture site. So after doing thorough debridement, I applied Elizarov fixator and kept beads. So once the infection was reduced, then I compressed the fracture site and did corticotomy here to gain length. And that was the final result. Coming to non-unions, non-unions can be aseptic non-unions and infected non-unions. Aseptic non-union can be with deformity or without deformity. Elizarov fixator is very useful in treating aseptic non-unions with severe deformities, and of course in infected non-unions. So this is an aseptic non-union. It's a hypertrophic non-union. This is present since 2 years, and he has a mild deformity also. So in this case, I applied the fixator and just distracted the non-union. And just by distraction, there was bone formation at the non-union site. And he united in just 4 months. This lady had aseptic non-union, but had huge procurvatum deformity, almost 90-degree procurvatum deformity. It was a stiff non-union, and soft tissues on the posterior side were contracted. So I applied Elizarov fixator and applied hinges and distraction bar on posterior side. So when I distracted the distraction bar, the deformity was corrected. You can see opening wedge correction here. And just by correction of deformity, the non-union united. Coming to a more complex problem, and that is infected non-union. Important causes of infected non-union are open fractures with a lot of contamination, and of course, post-operative infection after internal fixation. Infected non-union can be classified in mainly 3 types. Type 1 has mild infection. A bead or 2 of pus come in the entire day, or even there can be a non-draining sinus. So the infection is mild in type 1. In type 2, the infection is moderate, but usually there is no gap, or the gap is small, less than 4 centimeters, and there's no shortening or deformity. And type 3 has severe infection, and it has deformity, gap, shortening, or combination of all three. Important principles of treatment of infected non-union are control of infection is the most important thing. And for that, we have to go for thorough debridement and then insertion of antibiotic impregnated beads or rod. Use of vacuum assisted closure system, VAC system, is also very useful. And the second principle is, of course, stabilization of fracture. One can go for internal fixation after control of infection, or one can use ring fixator right on the day 1. So what do we mean by thorough debridement? In thorough debridement, we remove all the loose pieces, sequestra the bone, then resect all the infected soft tissues as well. We have to resect the dead bony ends till we get good punctate bleeding from the bone ends. Intramedullary reaming should be done to remove small intramedullary sequestrae and infected soft tissues in the intramedullary cavity. After doing thorough debridement, we can insert antibiotic impregnated cement beads or intramedullary nail. So coming to type 1 infected non-union, as I've already told you, it has a mild infection. So we debride these non-unions and stabilize them. This is a case of type 1. He had mild infection, but the non-union was mainly because of unstable internal fixation. So I debrided it thoroughly, put antibiotic beads, and at the same time, I changed the unstable fixation into a stable one, and it went on to unite very nicely. Another case of type 1, the infection was very mild. Actually, he had non-draining sinus since a long time actually. And in this case also, I did debridement, put beads, and applied Elizoro fixator on the day 1. In this patient, I gave cycles of compression and distraction. This is called as accordion maneuver. So you compress for 10 days, take a rest for 10 days, and again you can go for distraction for 10 days. So such cycles stimulate bone formation. And he had a very good union with complete eradication of infection. Coming to type 2 non-unions. So in these, the infection is moderate. And in these cases of non-union, usually you require a staged procedure. So in stage 1, you go for debridement and insert antibiotic rod or beads along with X-Fix. And then after 4 to 6 weeks, we remove everything, repeat the debridement, and then replace it with interlocking nail. And bone grafting can be done at that stage. So this is one case of infected intramedullary nail here. So everything was removed. The thorough debridement was done. The devitalized bone ends were freshened, and antibiotic impregnated cement rod was inserted along with Elizoro fixator. So here, Elizoro fixator was used for rotational stability and to give compression at the fracture site. So this was in situ for 4 to 6 weeks, and then it is removed, and we insert intramedullary interlocking nail. Bone grafting was also done in this case. This is an infected plate. This was also type 2 non-union. This lady had this non-union since 2 years. Her non-union site was, bone was exposed here. There was non-healing wound since 2 years and was throwing pus. And she had severe pain. So I removed everything. I removed the plate. I did debridement. And I resected the bone ends also, which were devitalized. Applied Elizoro fixator, kept beads inside. And once the infection was done, actually I closed the wound over the beads. And when the infection subsided, I removed the beads and did a corticotomy above and did bone transport. So I transported this fragment down to close the gap. And the gap was closed. And she had excellent union with absolute complete healing of the wound. Coming to type 3 non-unions have severe infection. They have gap, deformity, shortening, or combination of all the above. And the treatment of choice in these non-unions is elixir of fixator. So this man, he actually is a famous TV actor, had a ghastly accident, and then he was plated. He developed bad post-op infection, so he was debrided, plate was removed and again replated and again debrided. So he was suffering for 5 years. There was severe infection, he was pouring pus. So I removed the plate, I did thorough debridement, I resected all the dead bony ends, kept beads and applied elixir of fixator. In this patient also, I gave cycles of compression and distraction, the accordion maneuver, and he had a solid union. It took long 7 months, but he had a very good union with absolutely no infection and full range of movement. Again, a badly infected case. This 18-year-old boy had road traffic accident. He was actually flown by an air ambulance and was treated immediately. But unfortunately, he developed post-op infection. He was plated. So plate was removed, he was debrided, but bone just refused to unite. The bone ends were sclerotic. There was gap, there was shortening, and he was throwing a lot of pus. It was severely infected. So I did a debridement, a good debridement, and then I applied elixir of fixator. And I just distracted the non-union. He had 3 centimeters of shortening, so I just distracted it for 3 centimeters. And there was transformational osteogenesis. That is, the bone formed in the gap which I distracted. And he had a solid union. Now coming to post-traumatic deformities. Post-traumatic deformities can be due to growth plate injuries, and because of growth plate injuries, there can be angular deformity, limb length discrepancy, epiphyseal or joint distortion, or combination of all these. So growth arrest can be a complete growth arrest or a partial growth arrest, and it can lead to bony bar or physeal bar formation. So it can be a peripheral bar, a central bar, or a complete bar. So if there is a peripheral bar, usually there are angular deformities. A central bar causes tenting and articular deformation, and a complete bar causes usually shortening. So the treatment options are resection of bony bar and insertion of adipose tissue or bone cement in the gap to prevent recurrence of formation of bony bar. If the angular deformity is more, then just resection of bony bar is not sufficient. We have to add a corrective osteotomy. If bony bar or the physeal bar is large, then there is no point in removing the bar. So we go for the third option, and that is ablation of the growth plate and corrective osteotomy. If the growth plate is already fused, then we directly go for corrective osteotomy. And if there is shortening along with angular deformity, we go for the fifth option, that is corrective osteotomy. So if the bar is less than 30%, then we go for bar resection, or the growth remaining is more than 2 years or more than 2 centimeters, then we go for bar resection. And if the deformity is more than 20 degrees, we go for simultaneous osteotomy. So first we map the bar on MRI preferably, and then we approach, the central bar is approached through the metaphyseal window, or even an osteotomy sometimes in the metaphysis. A peripheral bar can be approached directly after excision of periosteum, and the bar is removed with high-speed bursts with continuous irrigation. And 2 millimeter normal area around the bar is usually removed. So it can be even removed with sharp curettes. And after removal of bar, we interpose adipose tissue, preferably taken from gluteal region. So cases, this is a case of posterolateral bar in a 12-year-old girl. It was a peripheral bar. So I removed the bar and corrected the deformity with the laser fixator. You can see complete correction of the deformity as the X-ray, and that's her function. And this is a 3-year follow-up showing absolutely no recurrence of the deformity. This 13-year-old boy had road traffic accident in childhood, and gradually over the years he developed this deformity. He was actually not walking but was hopping like that. Actually, he didn't have fixed flexion deformity of the knee, but he had this severe procurvatum deformity in the distal femur. You can see the distal fragment is in procurvatum valgus and it is rotated also. And this entire segment is very sclerotic. So I removed this sclerotic fragment, corrected the deformity and applied a laser fixator. I compressed here and then again distracted it to gain length. So you can see his deformity is fully corrected, his knee is straight, but he was still short by 4 centimeters. So I lengthened his tibia for femoral shortening with a technique called as lengthening over slotted plate, which I have developed and published in Indian Journal of Orthopedics. So that was his femur, and that's him. This is his 2-year follow-up showing full function. This boy had a road traffic accident, again 5 years ago. He is now something like 14 years old. So you can see there is valgus deformity in the femur and varus in the tibia, and he has about 8 centimeters of shortening. So you can see the soft tissue is scarred, and this is how he is walking. There was a lot of shortening, 8 centimeters of shortening. If you see his mechanical axis, it is deviated on medial side. So I did anatomic axis planning in this case and found out the cora. So the hinges are kept exactly at the cora to correct the deformity. So I applied a laser fixator and I applied these hinges which were at the cora. Though the osteotomy was done lower down, the hinges were kept exactly at the cora. And these hinges are also distraction hinges. So along with correction of deformity, I get length also. Same thing was done for femur. In femur, the hinges are on medial side. These are just opening wedge hinges because I didn't want to lengthen his femur. So femur is also corrected and tibia is also corrected, and 6 centimeter of lengthening was done in tibia, and that was his final X-ray. You can see the mechanical axis is perfectly aligned. So that's his clinical photo and that's his function. Again, a case of lateral physial bar. It was also peripheral bar, but this time the bar was more than 30 degrees. It was almost more than 50 degrees. So I did complete ablation of the growth plate and look at the mechanical axis deviation. It's a huge valgus deformity in the knee. This is how he was walking. He also had a little bit of recurvatum. So I applied a laser fixator and corrected both his valgus and his recurvatum. And that's the final X-ray. And that's his function. So this is how he is walking afterwards, and this is how he used to walk before. So huge improvement. So this girl had road traffic accident 8 years ago when she was just 8 years old. Now she's 16 years old. And you can see she had growth plate injury in the proximal tibia. So the tibial plateau is completely deformed. She had very bad skin. Skin was grafted at many places. She had equinus of the ankle because of shortening. And you can see here there was valgus and recurvatum deformity. So it was an oblique plane deformity of tibial plateau. This is how she was walking. You can see it very well on this 3D reconstruction on CT scan. So the tibial plateau is sloping posteriorly like this, the severe recurvatum and valgus. So the deformity was almost 60 to 70 degrees. So I applied Elizaro fixator, and you can see the ring is parallel to the tibial plateau in lateral view and AP view both. So this is an oblique plane deformity, and the hinges are perpendicular to the plane of the deformity. And the distraction bar is placed on the concave side. Osteotomy is done here. And the deformity was corrected simultaneously in both views. You can see it's corrected in AP view and lateral view simultaneously. Her equinus was also corrected with Elizaro fixator. And that's the final result, complete correction of the deformity. That's a clinical picture. So for conclusion, I would like to say that Elizaro ring fixator plays a vital role in treating badly infected non-unions and complex deformities. So I thank you for your kind attention. Thanks.
With this, I would like to thank all the three speakers, Dr. Joan Arakal from Australia, Dr. Ruta Kulkarni from Miraj, Dr. Ashok Sham, who has given us this opportunity to bring this webinar to all of you, and most of all, the IOA for allowing the women's cell to prosper and grow and go from strength to strength with its academics and other activities. Thank you.